Welcome to Rays of Hope, Masikhanye, a show that is hosted by the Cape Conference of the Seventh-day Adventist Church. And this is a show that aims to divide light from darkness and helps us to cope in our daily lives. It's a show aimed at individuals, at families, as well as the communities. We should just go out and rise and shine so that we have a better community. God's word in Psalms chapter 27 verse 1 says, "The Lord is my light and my salvation. Whom shall I fear?" Join me with some of the experts that I'll be having on the show in trying to shed some of the light God has given them through their expertise and knowledge. Right now I have with me Dr. Luyanda Mbanga, who is going to talk to us about vaccine and COVID-19. Welcome, Dr. Mbanga, to the show.
Thanks, Prof.
Thank you. I'm happy that you are here to shed some light to us and to our viewers as well. How do you manage COVID-19 at the hospital?
Okay, so the mainstay of treatment of COVID-19 is usually, symptomatic treatment, whereby people come in, and we know that there is a mild disease which usually does not need much, just needs observation and symptomatic relief of whatever patients came with. And then you get a spectrum of patients coming with severe disease, whereby they have respiratory failure, they have difficulties in breathing, and they'll have low oxygen saturations when you check on the pulse oximeter. And obviously, if you have low oxygen, you need supplementation of the oxygen, which is we need oxygen, we give them oxygen. And then secondly, we have seen that there's evidence that dexamethasone has shown to be beneficial for these patients, especially people who have worse or severe presentation, whereby people will have low oxygen saturations, they may benefit from dexamethasone. And also what we've seen is that, there are different types of oxygen. There's 40%, which you give by face mask. There's the nasal prongs, which is a lesser saturation. And then if you fail on those two, which are usually the first, attempts, then we can escalate that and give you the non-rebreather mask, which has a reservoir. It gives you more oxygen concentration. Again, if that doesn't work, we further escalate and give you high flow oxygen, whereby we put you on a machine which basically gives you high concentration of oxygen, high flow at high FiO2s. And primarily what that helps with is for you to get as much oxygen as you need, because primarily, and what we know is that severe disease will come with respiratory ailments and presentation. And a person who's not doing well on the high flow oxygen, then we have to further escalate, whereby now we think of mechanical ventilation. Mechanical ventilation essentially means you have to intubate a patient, try to sedate them, and then transfer them to an ICU setting, whereby they'll get monitoring, they'll get support of the machine. And once they've done better, then we sort of remove them from the machine. So we've actually seen that in the Western Cape there's been there was almost a shortage of oxygen because of the demand, because most of these patients will need to be on oxygen, and that's the mainstay at this point, because other modalities are still under investigation and under clinical trials, so we don't have a definitive form of treatment at this point. But oxygen plays a good role, dexamethasone, and of course there are some adjunctive measures we do, such as proning the patient. People get better. And also what we've seen is that there is a cohort of patients who will have, like we said earlier, pulmonary embolism. Therefore, you also need to anticoagulate those patients because they are prone to coagulation, to clotting, to clotting. So you may need to give an anticoagulant in the form of Clexane, high dose Clexane. But again, you have to tailor the management as per the patient. So there's no umbrella management, but you have to tailor the management as per the presentation, the severity of disease, and the response to initial treatment.
Thanks a lot. I love the way that you're explaining it, and I like the fact that you've also mentioned that one of the ways which people can also use at home to improve their oxygen sets and oxygen flow into the lungs is to prone them, to lie
on your tummy,
face down on your tummy. It actually makes a huge difference.
Yeah.
Now, there is another challenge that we normally find with patients with COVID or who have tested COVID positive. Now, when they have to go back to work, they are often required by the employers to take a test again. What do you want to say to us about
Thanks a lot. In fact, we've seen a lot of patients who come in and demanding a second test, and coming to us with the first test, now demanding to be retested, and then we didn't understand where this came from, because there's no guidance as of now. There's no national guideline or even an international guideline to say once you've tested positive, for you to go back to work, you must have another test. Remember, a positive test does not always mean disease or activity. So you can have a positive test and you're definitely infectious at the time, but after those 10 days of isolation, we understand that you've shed off the virus and you are asymptomatic, and usually you are not infectious. Yes, you're not infectious. So there is no chance of you transmitting whatever you have to the next person. What the test can pick sometimes, it can actually pick the dead virus, which is not causing any clinical disease at the time. So it is not advisable and it's not recommended. You just isolate after those 10 days, you go back to your employer and you go back to work. There is no guidance that say we must have a retest. And remember, what that has done or what that can do is to even increase the burden of the burden of testing, whereby you have people who come in with acute presentation, they do the test, and then you have people who've finished their 10 days of isolation, now they want a retest. That creates a huge backlog. So we only want to test people whereby the test is going to have an impact in terms of management of the patient. So if you feel better, you've completed your 10 days, you can just walk back to work and start working. You do not need to retest. And that's a huge problem which we've faced as clinicians.
Just continue sanitizing your hands, washing your hands.
Absolutely.
And you also continue wearing your mask.
Yeah, again, let me emphasize on that, because there is this fallacy that once you have COVID-19, you are all free. You can go to parties, you don't have to sanitize because you've had it. It's
you've got antibodies.
Yes, yeah. It's a false sense of security, because you never have to put your guard down. You must always be ready to defend yourself and to prevent further disease. We've actually seen people who've had COVID-19, the first wave, and now present again with another positive test and symptomatic and clinical picture of COVID-19.
So reinfection is
yes,
a real danger.
Reinfection is something we've seen. And just to speak to that, I mean, we recently, there was an emergence of the variant to the strain we had before. Yes. Yeah, so that, you may have had the first strain and you may have had some antibodies to that. But the one thing we don't know is how long the antibodies last for. So you rather err on being cautious and just do what you have to do, sanitize, put a mask, because you don't know how long you have the antibodies for. And secondly, you may have antibodies to one strain or another, and then another strain you may not be as immune to that. So there's a lot of information that we don't know yet, and there's research every day. We're getting more information every day. But I think the simple message is, let us be cautious, let us sanitize, let us stay at home, let us wear our masks, and let us not go to super spreader events.
We should be alert all the time and not be found with our backs on the wall.
Yes, absolutely.
The government is busy talking about the rollout of vaccine.
Yes.
What is a vaccine?
Okay. Very interesting. It's actually not a new, thing in South Africa. It's not a new term, as you may know. There is an immunization schedule which most kids underwent through. So vaccination is not new. I don't know where this, uncertainty and this noise is coming from. So to answer your question, a vaccine essentially is a pathogen or a biological agent which is similar to the actual virus, which is given to the patient or the client. And that is given for, primarily for reasons of trying to gain immunity, meaning you are training your body to fight this pathogen. Now, there are different types of vaccines. Sometimes you get live attenuated vaccine, meaning it's an actual virus, but it's attenuated, meaning it doesn't have the power to mount disease. Sometimes you can get inactivated vaccines, whereby there's an injection of this pathogen, which is inactive. It will not form disease. And of course, sometimes you can get virus-like particles. So what has to happen is you must get this pathogen, which is similar in constitution to the actual virus. And once you get that, your body will mount immunity, meaning your body will suddenly get soldiers out because they've seen that there's an attack. Once you get your soldiers out, the soldiers are ready to attack. But remember, it's not the real virus. Such that when you get the real virus, you have all your troops out. They are ready to attack because they were primed or they were,
so it's
prepared.
If we can use simple terms to explain it, it's just like a rehearsal.
Yes, absolutely.
In other words, it's like if you're in a country, you have soldiers at the borders. And then you have a mock attack, and then the soldiers are ready.
Absolutely.
So that when the actual attack comes in, those soldiers are already ready and they know how to take their defense.
Absolutely.
I'm happy about that. So it means that a vaccine is something that is quite good for us, and it will prime our body so that we respond aggressively and we destroy the virus very well. What are the advantages? Maybe this is one of the advantages of the virus, that it primes your body up so that you can respond in a much more aggressive manner.
Yes.
What are the disadvantages of the virus?
Maybe just to go back, Prof, to the advantages you asked for. So we've seen people who say, no, I will not take the virus. I have a strong body. My body will. That is partly true, because if you've had COVID-19, you are likely to have immunity, meaning natural immunity from the virus itself. However, the downfall to that is that you are likely, sometimes to have complications of the COVID-19. So if there is a way of getting immunity without you having go through the complications, why not? Because what the vaccine will do, it will get your body ready and you will have immunity, but you may not have the complications because you do not express disease. So obviously, advantages are, prevention of actual disease. And number two, one thing we've seen is that it's cost effective. It's cost effective to just roll out vaccine than to admit the entire, population to the hospital. So it's cost effective, and you are likely, there's certainty that you are definitely immune to the condition.
So in other words, you're saying to me, if one has had COVID-19 infection or disease, that person is not immune, he can get infected again.
Yes, absolutely.
And then in terms of vaccine, should I take vaccine after having had COVID-19?
Okay, so what I said earlier is that this is a novel disease. We don't know a lot about it, and there's research going on every day. We would definitely say people must take the vaccine, because our information and our knowledge is in evolution. There's new data every day, but as of now, we say people must take the vaccine, because for the reason that we don't even know how long your antibodies last for, even if you had the COVID-19. So you'd rather err on the side of being cautious and take the vaccine than to think your body is all fit and ready for the pandemic.
Will we still wear mask? Do social distancing after the vaccine?
Yes, absolutely. That's a good question. So there is this tendency of thinking that when there are interventions, it means we're just going to break loose and go back to the things we did pre-COVID-19. Well, quite certainly, our lives will never be the same again. We have to appreciate that. Yeah, our lives will never be the same again, and this is likely to linger with us for a long time. And, history must teach us, because we've seen previously, Spanish flus whereby there was resurgence, such that sometimes the second and third wave were more, aggressive than the first wave. So we cannot stop sanitization. We cannot stop wearing of masks, even if we are vaccinated. Yeah. So we have to.
My last question quickly to you: will the vaccine change my DNA makeup?
So again, that's why a misunderstanding that we hear around people who are saying they won't take the vaccine because they link to the DNA. It will not. To answer your question plain and out, it will not. And like I said before, it's not a new thing. We all were taken by our mothers to clinics for measles vaccines, for polio vaccines, and here we are. In the year 2000, the US was able to eradicate measles because of vaccination. Smallpox was eradicated because of vaccination. So, and in 1995, South Africa started rolling out hepatitis B vaccine. And since then, we've seen reduced, incidence and prevalence of hepatitis B. So it's something we must take. It will not change our DNA. In fact, it will make our livelihood even better.
Thanks a lot, Dr. Mbaga. It's been nice to have you on the show and to give us some pearls of wisdom, which I hope we'll be able to make use of. To our viewers at home, these are pearls of wisdom. Please take them, use them. Not only use them, but go out and be a light in the community and shine out there. Remember, we are the light of the world, and we need to go out and to shine throughout the world. Don't go away. Stay right put. I'll be with you after the break. Welcome back to the Rays of Hope, Masikhanye, a show that is aimed at individuals, families, and community so that we can sit around, share the light that God has given us, and spread that light throughout the world. With me, I've got Dr. Nhlabati, the psychiatrist. Welcome to the show, Dr. Nhlabati.
Thank you, Prof. Thank you for having me.
Thanks. Let's talk about stigma. We know that with COVID and mental illnesses and many other illnesses for that matter, stigma is always attached. What is, why stigma? What do you do as psychiatrists in terms of making sure that we are out of this?
Yeah, I think maybe we should first look at understanding why we have the word stigma and what it is a result of. So stigma is mostly associated with fear. Fear of the unknown, or fear of something that you don't quite understand and you have no information about, and it looks dangerous, So stigma exists, for example, in the context of mental illness, where we don't have enough information in our communities for people to be able to recognize somebody that is ill. Most of the time, people who are mentally ill are shunned by their relatives. People assume that mental illness equals to people that suffer from mental illness that we normally see, homeless, walking the streets, In the context of COVID, it's also fear that leads to stigma because we are scared of dying. And as we spoke in the earlier show, it's something that people are not used to. Fear is a normal human response. It's about survival. Fear allows us to be alive. You can imagine if you were living as a caveman before, and you were hunting in the jungle somewhere, fear of a lion roaming around is what would make you stay in your cave overnight in order to be safe. So we are always trying to survive, and that fear leads, or that fear encourages our survival. So what can be done in order to address stigma is that information should be made available.
I like that. Information, very, very important.
Yes, and it's not,
stigma.
and it's not just a responsibility of medical professionals. The church, the religious community, in South Africa has a responsibility for providing congregants with proper, scientifically proven information.
Which is what we're doing now.
Which is what we are attempting to do now. Also, COVID comes with a lot of debts, so the ritual that happens after somebody's passing, it has been disturbed in terms of what is happening now and what would happen previously. I think the rules are you need to bury at 72 hours.
Within 3 days, 50 people,
yeah.
And also no night vigils.
Yes, and we come from communities where a funeral is an event, where you probably bury your relative a week to 2 weeks later whilst you're waiting for the uncles to come, for the relatives to come, trying to gather money, in order to facilitate this funeral. And part of those rituals help us get through the ritual of grief after the passing of a loved one.
In terms of coping.
Yes, in terms of coping and coming into terms with the fact that the person is no longer here. So what is happening now, we are not getting the opportunity that we used to have before, where we would go through the process with our families. And that is causing a lot of distress in families. Families are fighting with each other. You didn't come to my mom's funeral. I'm not going to your mother's funeral. These are the dynamics that are going on in our families. And those dynamics will be fixed if information is provided, if church organizations say to their congregants, it is okay to not need to have a night vigil. It's okay to not need to have food after, or it's okay not to have an after tears party, for the whole night.
So in other words, this information has got to be there and be provided.
Yes.
Not only once, but it should be
over and over again by the relevant stakeholders, yes. So you also asked about stigma in the context of HIV and
yes.
vaccines. That is another
especially
big
vaccines.
Problem.
As we know, they are going to be here now.
Yeah, so I will be first in line, if I can, to get the vaccine. And the thinking is, I think one should learn from history. And if you look at certain challenges, it's better to look at what happened before, because nothing is new under the world.
Even Solomon says there's nothing new under the sun. Yes,
there's nothing new. Most of these things have occurred before, or scenarios that are similar. And if we look way back at the Spanish flu, yellow fever, etc., polio, for example, diphtheria, tetanus, these are all diseases that are life-threatening, that we have been able to survive as humanity because of the presence of vaccines. So maybe I wouldn't be here, maybe you wouldn't be here. Life expectancy long ago was at a low level. It was a miracle if you lived past the age of 30, but now we've got people living to the age of 100 because of vaccines that worked in the past in similar circumstances such as these.
So where can we access mental help?
Well, there are several organizations that are available. I think most of the organizations now are easily accessed over the internet. So you've got websites like the one for the South African Anxiety and Depression Group, SADC. They have call centers where you can call and have a therapist talk to you, and a therapist that can direct you if they see that you need further professional care. There are websites like Dementia SA. There are videos on these websites that will tell you about different types of mental illnesses, what medications are used for those, and what community groups or like support groups are available in these communities. For example, Narcotics Anonymous, groups for people who are caring for patients that suffer from dementia. There's a lot that is available out there. For people that don't have access to the internet, the local clinic is your first port of call.
I like that. The local clinic always
Yes.
is available, readily available to us. And I think that's where they can channel us and take us to the right direction.
Yeah.
I just want to know from you, do you think we'll be seeing more of mental health disorders with the COVID-19 pandemic and in the light of the vaccine?
I think,
And why?
well, these are still, I suppose, data that still needs to be gathered. We don't know much about COVID and the long-lasting effects of having had COVID and the effects of humankind having gone through COVID. So there have been anecdotal papers citing fatigue, chronic fatigue syndrome, where it takes you a very long time to regain your physical energy. It can take 3 to 6 months after having suffered COVID. We've seen a lot more anxiety disorders popping up. We've seen mood disorders, particularly depression, popping up. But this is all now during the acute to intermediate phase. We are not sure what will happen as sequelae to COVID in terms of neuropsychiatric symptoms in future. So it remains to be seen.
You have mentioned something very important, that human beings are social beings and they need to socialize. And I know we have touched this, but I just want us to go back to it once more. In terms of churches that are closed, in terms of us not being able to see our relatives, we can't socialize. What do you think? How can we cope in that situation? What is the solution?
I think there's a lot to learn. There's a saying that says, necessity is the mother of all invention. Well, the internet was not invented now, but there are companies like Zoom, for example, that were relatively unknown pre-COVID. Zoom is a platform where you can have video meetings. And platforms like that can be used, firstly, to maintain contact and connections between families, but also to maintain contact with your larger social support system, which would then involve the church or a golf club that you belong to, where programs such as this one can be used. So, for example, church services being scheduled at the same time every Sunday, but the difference being that it occurs online. I think the other thing that we need to come to terms with is COVID is still going to be around us a lot and for a longer time, and we have to be able to adapt to change. And if we are not able to adapt to change, to be open enough to reach out, to seek help, whether through pastoral care, whether through your local clinic or through friends and family.
So that means as a church community, we have a lot of responsibility to support one another, to see to it that each member of the church is well supported.
Yes.
As you've correctly mentioned, Zoom is available now. We can have our Sabbath worship services over Zoom.
Yes.
And we can actually fellowship over Zooms, and families can come together.
Yeah, from all over the world. They don't
and
need
meet
to
over
be there.
Zoom and talk.
Yes.
We before we had telephones that we could use, but now we can actually see one another via Zoom and chat. And more than anything, I think we still need to support one another in prayer.
Yes.
Prayer is very, very important. The spiritual aspect of the whole issue can never be undermined.
Definitely.
I think it's very important for us to to have trust in God, and to pray wherever it's possible. That will also bring a balanced lifestyle, because, as we say, sickness is not the absence of disease is not the absence of sickness, but we have to be physically, mentally, and spiritually well balanced for us to be good Christians.
And not to lose hope, and to, rely on whatever higher power you subscribe to find meaning and to find hope, to go forward for the future.
And obviously for us is trust in God.
Definitely.
We believe in God, we trust God, and we know that with God everything is possible. And even if things don't go the way that we want, but the fact that we know that God is there to sustain us. Doing a subspecialty in neuropsychiatry, and we are looking at the elderly.
Yes.
Just take me through the effects of COVID on elderly. You've mentioned earlier on that the elderly are always kept aside, they are protected, no visitors allowed. Do you want to take me through that and the psychiatry?
Yeah, I don't know if you should ask that question, because I can talk the whole day about old people. But we'll talk about the elderly, I suppose, in the context of COVID. So I work both in private and in government sector, and we've had an increase in the number of elderly that are coming into the hospital. The increase into the tertiary institutions is because that was the population that we were trying to protect the most. So if an elderly person who had a psychiatric problem came into a casualty, they would try and get that older person out of casualty quite quickly in order to try and limit their exposure to COVID. So we got to a situation where we can't really say no. As long as you're elderly and you have a psychiatric illness, we're going to take you. But what that did was that because there was restricted access also into our institutions, they would come in and you'd find that the elderly have to sit for months, without having a single visitor, sit for months without having a phone call.
Sure.
Elderly are an at-risk group in the first place, because it's not every elderly person that has social support or they have a family around them. So there are things that we tried to do to help them out. We've had to find an iPad, a tablet, in order for families to be able to use these platforms like Zoom, Microsoft Teams, in order to communicate with the elderly. The other thing that we are not always aware of in the elderly is the elderly tend to start behaving in an abnormal manner at some point during their older years. And most of the time, we are not awake to the fact that this might be a mental illness. We often dismiss the elderly as being difficult. The elderly can do whatever they want to do and they get away with it, and we say it's just because they are old. In the rural areas, we've had episodes where the elderly are accused of witchcraft because maybe they were psychotic and they were undressing or walking around at night. And we've had elderly being abused, their homes burnt because of stigma, because people don't really understand what is going on. So during a time of COVID, one wonders what is going on, because communication and access to resources is still very much compromised. It's important for us to care for our elderly, because it's been shown that the global population, thanks to vaccines, is aging. We are growing older, so there's many more older people that are around now, because the mortality rates that were there before have actually dropped. So we will find more people in our hospitals who suffer from cognitive deficits, who suffer from functional decline, who will need our help going forward. So if it was a tip that I can give to government and just the public, it would be to invest in mental health care in the country and, to encourage universal access. It shouldn't be about having money or not having money. It should be one of those basic needs that are met for every individual.
I think that tip applies to us as in the Christian community as well, because the Bible says, honor your mother and father so that their days may be longer. It means that we really have a responsibility to look after our parents.
Definitely.
In spite of COVID and in and outside of COVID, as a church community, as a Christian community, we have a responsibility
To
towards
take care
our
of our elderly.
elderlies.
Yeah.
Thank you, Dr. Tlabati, for coming to our show and giving us the pearls of wisdom. We wish you all the best for the future. To our viewers at home, please don't go away. After the break, we'll be having another guest. Thank you. We are back on Rays of Hope, Masikhanye, a show that is meant for individuals, families, and the community. We are still on the topic of pandemic and how to negotiate through that pandemic. And with me, I've got Pastor House.
Hello.
Welcome back to the show, Pastor House.
Thank you so much.
We're happy that you are here.
Thank you.
You are a clinical pastor. Now, one of the things that I've seen happening is that patients, they go to hospital and their visitors are not allowed at the hospital. They never see their families and the families are worried. The patients never see the families. How do you navigate through that as a clinical pastor?
Okay. In the previous show that we discussed what a clinical pastor does, we spoke about utilizing the resources of your membership, like in my case where I'm also a district pastor or a minister. And one of the solutions we came up with is the church sponsored a phone and some data. So we worked, and this is where the clinical setup then works very well, is that we approach the social workers within the hospital. And in partnership, as a team, we would then have this phone, and as the social workers would do their rounds, they will note which patients long for their family, or which patients haven't been able to connect with their family yet. And a lot of our patients within our government institutions, they don't have the resources in order to have a smartphone that can video call or something like that. So we also look out for those that don't have access to that facility, and then we utilize this phone to phone the family. We, as a clinical pastor, I would then first speak to the family members and ask them, is there somebody that has access? So I would phone them. Somebody that has access to a video call. Then we set up a time. We arrange that this is going to happen. And then we assist them in speaking to their family. Now, that little interaction shows us that we are so much more than just physical beings. There's this interconnectedness, this context that actually helps towards well-being. And just having this little ray of hope of seeing your family member, speaking to the doctor, seeing how well they are looked after, it creates hope within the patients and then the family.
Indeed, it does make a huge difference, both to the family and the patients, and the patients' recovery too.
Yes.
Now, we also have a problem of people or healthcare workers that are fearful in terms of this pandemic. They're fearful of going to work. You have porters, nurses, doctors that are fearful of going to work. How do you, as a clinical pastor, assist in that aspect so that they've got less fear?
In my experience, and this is all anecdotal, so there hasn't been time to do proper research on it, but, we've been through the first wave, which was kind of isolated to your COVID ward. Your staff that were working there, they knew what they were prepared for. It was those that didn't have comorbidities, that were a certain age, basically just reserved for the healthy. And now with the second wave you had where whole institutions would have in every single ward COVID patient. So from your cleaners to your nursing staff to your administration staff, all of them were now exposed to this pandemic. And you had a lot of fear. That was, as you have rightly said. So you had people just not pitching up for work. So there was this dynamic of job security that also came in. And we started realizing that there's a need for staff support groups.
Exactly.
And we, in the clinical team again, we organized it. The CEO kind of drove it at the institution that I was in, getting everybody together and making sure that your managers, your line managers, they encourage the staff to attend. And the fear aspect came up in every single session. And what we tried to do was to create perspective.
Okay.
Perspective in the sense that most have seen a patient die. So the fear of seeing a lot of patients die, how do we bridge that gap from this unknown factor to what they've already experienced, something trustable, if I can use that word, and then linking the two to create perspective that, are you following protocol? Have you spoken to somebody that's worked in the COVID ward before to give yourself the
insight and the information?
Yeah, the insight and the information of what it's really like. And you found, and this is again where the pastoral care comes in, is that a lot of the fear wasn't necessarily for their own lives, but taking the virus back home because I have a grandmother, I have children, I have something. And one of the things that I also picked up was that this uncertainty kind of brought back previous trauma. And you had a lot of this, I wouldn't call it post-traumatic stress, but you would kind of get that sense that unresolved trauma of the past was being unearthed in the uncertainty that they are facing now. So then it was kind of helping them to see past that and making sure that they are focusing on that which they have control over. Not live in the what-ifs, but in the what-is. And that has really helped to overcome this fear. So it's putting the knowledge, the power of knowledge, into the hands of your healthcare workers. Giving them the platform to ask without fearing that their job might be at risk. And I think there I need to say thank you for the leadership nucleus, making sure that there was a platform where people could express how they really feel without anybody judging or taking notes or anything like that. And I think that's where that sense of community was brewing again, is understanding that we are connected with each other.
Exactly.
Having a healthy nurse means it would be better care for a patient.
Thank you. Now let's come to the issue that is quite sensitive, the issue of vaccines.
Yeah.
We know that the vaccines will be rolled out. The government has announced that it will be rolled out starting with the healthcare workers. But in spite of that, there's a lot of fear and there's a lot of myths surrounding the virus. A lot is being said about it and equating it to 666. What is your perception of that?
Okay. I think we can start again in the philosophical dimension, speaking about the concept of fear. You would fear something if you don't trust it. And I think that is indicative of society at large, that we are not trusting anymore. So we don't trust our government, we do not trust, we do not even trust our elders. You have a lot of these voices or these communities that don't trust each other. And it's kind of a problem within the South African context as well, because of our historical injustices that have created this mistrust that permeates our society. So whenever something is introduced, we move from the position of mistrust. So when we talk about vaccines and we talk about linking it to 666, and it's kind of we first need to come back to the beginning of who do I trust? And I think in this instance, that's how I would encourage my members as well. To say, do you know a doctor? Do you know somebody that is a scientist that works within this field, a geneticist or somebody like that?
Virologist.
A virologist or that you know. And then make an appointment with that person. Write down your questions so that you work from the basis of, I trust this person. Maybe it's somebody that loves you or that is related to you. And then work from that premise, because then you take out that mistrust factor. So without linking 666 to vaccines, I would say start smaller. Start in a relational perspective before you go to something that we know our society is being fed with, this thing called confirmation bias, where your news feed on your Facebook, whatever, it just feeds your biases. It feeds your preconceived ideas. There's nothing new that's being introduced. So if you believe that the vaccine is 666 and you once clicked on something that has similar, the algorithm would prepare your news feed according to what they feel is your interest. And that's how our society is being polarized. You see what is happening in the United States. You see what's happening within the South African context. And I would then say, just put a break on all of that. Come back to the relational perspective. Find somebody that you trust.
Is there a spiritual link between the virus, the vaccine? Is there
the spiritual link, it's something that I think in the first wave, it kind of gave the ammunition that this is something that's being controlled somewhere. But with the second wave, it became more apparent that there's no fear and favor when it comes. This is not my field. So when I say this is a natural phenomenon, I'm meaning it's in the field of something that takes place because we're in a sinful world. So I would link the virus to spirituality in the sense of we're not in heaven yet. Not to a person's individual strength of faith or trust in God, and therefore they will not get the virus. And I've seen it. You have a whole family that comes in. You have a pastor that's lying there and the congregation is there. And why I know for a fact that it is not linked to your personal spirituality is sitting with that person next to his bed, her bed, allowing them to express their faith. And in their sickness, they say, Pastor, can I pray for you?
Yes.
How much faith do you need in order to, in this sickness, still see that I need prayer? That to me is a key indicator that the spiritual link is more in the cosmic conflict, if we, that's a link, but in the bigger scheme of things, not in the individual. Where the individual spirituality helps is, how do we nurture one another? How do we look out for each other? In my sickness, where do I go for my strength in order to the next day?
What is the position of the church regarding the use of vaccines?
The use of vaccines.
Because we know that it's coming, so I'm sure it's a question that everybody wants to know.
Yeah. So I can only speak from the perspective of the Seventh-day Adventist Church. And they've issued a statement, and it's, without reading it, just to summarize it, it's from the perspective of that God blessed the medical field. God's involvement in this world is throughout ages, walking with humanity, and he has clearly shown that he has blessed the medical field. So the advancement towards a vaccination, we can place God in that. Okay? Now the question of, will I be forced? The church's perspective is, from a church's point of view, we won't tell anybody to go or not go. We will leave it to your free will, because we believe that we walk with the Lord. We have been blessed with logic. We have been blessed with reason. Maybe let's use reason. more. And that concept that I brought out in the beginning, finding somebody that you trust, to know that we are part of a wider context. We have specialists in field. Let's put our trust in people that also serve the Lord. So from a church's perspective, there won't be a push towards getting your vaccination or not getting your vaccination. We will leave it to the individuals to do what they believe. Yeah.
Fortunately, we are also living in a democratic society.
Yes.
So the government cannot force anything on any individual. We've got constitutional rights that should be maintained and protected all the time. But what is the church doing in making sure that its members are kept informed regarding important issues like vaccine and COVID-19?
Okay. The important thing is you have a pastor. That pastor is the gateway between your conference, and here I'm speaking from the Adventist perspective again, but so let me speak to the wider context. Making sure that you get first-hand knowledge, not secondary information like a YouTube channel or something like that. Speak to a professional in the field. And how the church can help is having that networking, knowing this doctor is willing to do a presentation. Make sure other churches also tune in for it. Just spreading the information as we have it to our access. We live in a wonderful day and age.
Thanks a lot, Pastor House. We are the light of the world.
Amen.
If we need to be the light, we need to have the source of light, who is God.
Amen.
And we also need to go and read and equip ourselves so that the light that we are receiving, we are able to share it with the others. And once more, thank you for joining us, and thank you for empowering us. Remember, viewers, God's word says whatever we have received, we need to go out and share it. Let's go out this week and share the light that we have received. Let's go out and share the rays of hope that we have received. Masikhanye, let's go out and shine. Remember to hook up with us in our social media, as indicated on the screen. You can also email us with your questions and your prayer requests. We'll be able to respond back to you. The Lord bless and keep you. The Lord makes his face to shine upon you. The Lord may be gracious unto you. Till we meet next week. Thank you. Bye-bye.